Hi guys, so we are talking about one of my most favorite diseases in all of immunology, which actually sounds really weird to say. But we're going to talk about multiple sclerosis. Little known fact, I actually did my PhD work on models of multiple sclerosis and basically the immune mechanism behind it. So part of why I'm sitting here talking to you today is because of my fascination surrounding the immune response and multiple sclerosis. So I will try to keep myself brief and not let too much of that fall into what I talk to you guys about. But if you guys have an interest in it too, I'd love to talk to you about it. So multiple sclerosis, part of the reason it's so fascinating is that although we know the immune response plays a massive role in the disease, and many of us, myself included, believe multiple sclerosis is in fact an autoimmune disease, particularly a most likely a type 4 hypersensitivity reaction. There are those out there who actually do not think multiple sclerosis is autoimmune in nature at all, because it doesn't meet a lot of the criteria that we normally use to classify a disease as an autoimmune disease. That said, it doesn't stop many of us from thinking of it as one, and the immune response, inhibiting the immune response, is actually a lot of the way that we go about looking into ways to treat multiple sclerosis, which is stuff that we'll work on in your session activity and that you'll hear more about from your pharmacology discipline directors. So let's get into it a bit. Okay, mainly Pathophys is going to handle all of this, but I did want to talk about it a little bit. So as you'll see from other people, multiple sclerosis is a chronic neuroinflammatory disease. And basically what happens is that you wind up getting demyelination of the white matter. So basically you lose the myelin that surrounds it. So much like I talk about in your Guillain-Barré video, if you think of your neurons and axons throughout your body, almost like your headphones, which are hopefully attached to your computer right now, looking at me telling you this story about MS, or to your phone or whatever. I don't know about you, but I like to take off my headphones and like crumble them into a ball and stick them in my pocket. And eventually enough wear and tear happens where I get a little break in the rubber that kind of lines the actual wire that makes up my headphones. And at that point, that's around the time my headphones stop working, because now this wire is exposed. So you can think of myelin almost like the rubber that basically surrounds the wire that is your axon. So whenever you have a break in this, you actually get disruption of the signal. So here's that exposed nerve fiber, and now instead of the signal being nicely insulated as it goes down the axon to the site it's supposed to, it kind of, you lose it. There's interference. It gets it's no longer insulated, so it either you don't get enough signal or you get inappropriate signals. And patients with MS experience such a huge variation in disease and the types of symptoms. Optic neuritis was considered kind of a hallmark of the disease for a long time. Same with nystagmus and diplopia. But there are certainly other ones. So dysphagia, muscle weakness, difficulty walking, spasms, ataxia, pain is a huge part of it as well. So there are all of these symptoms that can be associated with MS, and basically they are all a result of the demyelination of basically these axons. So that's kind of the way I think of it. Now, when we think of MS, there's a couple main types, which again, I'm sure Pathophys will go into, but kind of the most common is relapsing and remitting. So basically, like the line shows here, you have an exacerbation, then you start to get better. Some cases you get all the way better and then have another exacerbation and all the way better. Those are, that's kind of the ideal, is that you're always going to go back to that initial baseline. Most patients experience some sort of difference between what's kind of normal baseline and where they wind up after an exacerbation. In secondary progressive, which is experienced by a significant percentage of patients as well, you wind up with you get this exacerbation, and then you see kind of a larger difference between, and then eventually you just kind of continue to get worse. There's no complete go back to baseline. It's just a constantly upward slope in symptoms or disability. So after an initial relapsing remitting phase, now we have relapse, remit, and get worse all the time. Then there's primary progressive. These patients do not experience any sort of relapsing and remitting. They have some onset of disability that just continues to get worse over time. These patients tend to have the fastest disease course and wind up kind of wheelchair bound or with the most significant deficits the fastest. And then there's progressive relapsing MS, where we can kind of see this constant increase in disability with some kind of peaks in disability before continuing to increase. So that's kind of the overview of what MS is. So let's talk a little bit more about kind of the immunology behind it. Okay, this is a really, really busy slide. You've got a whole bunch of immune cells here, but let's try to break some things down first. All right, so first off, we have this neuron right here. And along the neuron, we have the oligodendrocytes right here, right? See? So here it's technically, this is probably actually a Schwann cell, but either way, what this is these are the cells that are going to produce the myelin that provide that insulation along the nerve axon so that signals are transmitted clearly and directly to where we want them to go. In MS, you have some sort of immune-mediated response that attacks these cells and basically destroys them, and that's why we get demyelination, because we're destroying those cells. Okay, so that's kind of the baseline. Now, how do we even get here? Well, like most autoimmune diseases, we don't entirely know. There's some sort of combination of genetics, environment or trauma, and immune regulation that's failing ourselves really when this happens, okay? So for genetics, let's start there. Women, way more likely to get this one than men. So women, unfortunately, we're more likely to get MS. I think we're about 3 times more likely to get MS than men are. If we look at environment and trauma, there's actually a lot of data out there on this, but there's no particular agent that's been identified. EBV has been associated with it on and off over time. There definitely is some sort of etiologic agent because we know it's not all genetics. And part of the reason we know that is that if you have monozygotic twins, so identical twins, right? The concordance rate is only about 30%. So basically, if one identical twin has MS, there's only a 30% chance that the other identical twin will have MS. So it can't just be genetics. The other kind of argument for EBV actually comes out of the Faroe and Orkney Islands. Prior to World War II, the people there had no incidence of MS. World War II happened, and a whole bunch of European people moved in as part of the war. During the war, we saw a huge increase in MS in the Faroe and Orkney Islands. Then about 40 years later, after basically everybody had moved out, relatives had died off, things like that, the incidence of MS went way down again. So the theory is that this cohort that had a larger risk of developing MS moved into the area, bringing whatever the etiologic agent was with them and their genetics, which had them more predisposed, and that increased the risk of MS. And then over time, as they left and the etiologic agent maybe went away, the risk of MS went down. So for all these reasons, there might be some sort of environmental trigger for this. Immune regulation. Why do we say immune regulation? Well, that actually has something to do with kind of the disease cycle. So if we go back and look at kind of this relapsing, remitting cycle that we see with MS, we find that T regulatory cells can kind of overcome the effector response that we see during these flares to actually restore the immune response back to normal. So we know that they're capable. We just don't know why they're not actually making a response when we need them to actually control it. And obviously, anytime you have an autoimmune disease, your peripheral or central tolerance mechanisms are not functioning the way we want them to. Okay, so that's kind of the background. So what happened here? So there's a couple options for how this happened. We don't really know what kicks it off, but the nearest guess is probably some form of molecular mimicry, which we'll talk a little bit more in depth about in a minute. But basically in molecular mimicry, you have some sort of pathogen, and we make an appropriate response to that pathogen, and then that appropriate response cross-reacts with an antigen that is not pathogenic, like ourselves. So an example of this would be like rheumatic fever, which we talked about in your Jamie Lopez case, where basically the antibodies we make to strep then go on and attack myosin in the heart, and the patient gets rheumatic fever. Not that different now for MS, just we're talking about a different part of the body. So you have some sort of infection. The antigen goes into the lymphoid tissue. There, it's picked up by dendritic cells, or maybe it was picked up by immature dendritic cells at or near the CNS, and that goes into the lymphoid tissue regardless. If the antigen just gets into the lymphoid tissue, it might get picked up by a B cell. Either way, we have presentation to T helper cells. So this antigen gets picked up by this B cell, and it presents it to the T helper cell. It activates the T helper cell, and it also can activate, depending, especially if we're talking about EBV, which is a virus and therefore an intracellular infection, presents it to CD8 positive T cells. This leads to kicking off a whole immune response against, let's say it's EBV, that pathogen. Now, I'm not saying that EBV causes MS. I'm saying it's been associated. We don't know that it does or it doesn't. We just know that something needs to kick off the immune response, right? So that's why I'm talking about EBV for the moment, because it seems like a good place to start. So something kicks off this immune response. At this point, we have activated and class switched B cells. These B cells can differentiate into plasma cells. Now, they show them in the CNS. Yeah, you might find a few there. I would have actually put the plasma cell out here, but I would have put its antibodies in the CNS because that's where it would have wound up. In fact, finding IgG in the CSF used to be an early diagnostic marker for MS. So finding IgG there is indicative that you've got some sort of immune response happening in your central nervous system. Okay, at the same time, you've now activated CD8 positive T cells and CD4 positive T cells. It's not on this map, but that basically means that these cells that previously might not have been able to get into the brain can get into the brain now. They have the marker that will bind to VLA4, which is kind of like the door lock to the CNS. And once they can bind to VLA4, they can go ahead and get themselves into the CNS. They've opened the door to the CNS. So now they're in there. These CD4 positive T cells, these are likely to be Th1. Th1 is kind of the main mediator of this. You might see some Th17, but Th1 is a higher likelihood. So what does that mean? They're going to be producing a lot of IL-2. That's going to feed them. It's also going to feed the CD8s, right? And it's going to feed the B cells. Okay, that IL-2 is great. It's feeding things. It's also going to produce interferon gamma. Interferon gamma is going to feed macrophages. Macrophages are going to eat things that they think are infected. Here's where things get problematic. Remember, macrophages are innate. At some point, they just kind of get activated by kind of this massive stimuli in the environment. And more of these oligodendrocytes are going to get chewed away by the activity of macrophages, CD8 positive T cells that just go ahead and lyse things. And at this point, what happens is you have some sort of cross-reactivity as a result of this molecular mimicry. So think of it this way. At some point, our immune response wins, right? The interferon, the IL-2, the Th1s, the CD8s, the antibodies, they soak up whatever etiologic agent kicked off this immune response to begin with. But in some people, these antibodies and these T cells are cross-reactive for epitopes that are found in, say, our oligodendrocytes. So now, instead of just seeking out that etiologic agent antigen, they seek out the oligodendrocyte and they start attacking that. So now we have the CD8 cells that are killing that. We have the CD4 positive T cells that are being activated and stimulated to continue to produce cytokine that's going to feed this. You have them activating macrophages, you have them recruiting NKs and neutrophils and all sorts of other cells. You have complement being produced and you have antibodies being produced. And the immune response becomes overwhelming. Now, when a patient has relapsing remitting, at some point, the immune response starts to die down and you get an influx of T regulatory cells that seem to be able to quench this response, at least for a period of time. But what happens is, during all of this damage, new antigens were exposed. This is getting rather crowded. Let me switch colors. So new antigens are exposed. And when this new antigen is exposed, kind of the whole process starts up again, because now new T cells that are specific for this antigen are going to come in and attack. And it just becomes kind of a cycle of inflammation, shut it down, inflammation, shut it down. That's kind of the complex mechanism behind it. So I talked about kind of these new antigens and these cross antigens. So molecular mimicry is kind of the thought behind the cross-reactive antigens, right? So you have this pathogen in here, this little green circle guy, right? The self-tissue or the peptide mimic is kind of the same as this cross antigen, all right? So you get presentation of this pathogenic antigen to, and this is supposed to be V, so a viral specific Th1 cell. That basically activates that cell, it produces cytokines, it goes into the blood-brain barrier, it starts creating inflammation, and really all it's trying to do is to attack the infection. At some point, because this is so similar to this, it doesn't realize it, but this viral specific Th1 cell is no longer really a viral specific Th1 cell. It's now actually a self-specific Th1 cell, and it's going to keep attacking. Now, in MS, remember I said that as we damage those oligodendrocytes, we get kind of discrete antigens that are released and lead to new T cells being activated. Okay, so let's say in this peak, the antigens that the cells were responding to were viral antigen 1, which basically looked the same as antigen A. Okay, then as more and more oligodendrocytes got damaged, it released new antigens. In this peak, the T cells are actually specific for antigen B. In this peak, they're specific for antigen C. So we're creating new antigens, and that's called epitope spreading. So basically the initial event might have been really specific for that virus, but as the damage got worse and worse, we found new antigens to respond to. So originally we had this viral Th1 cell that was responding to a self-antigen mimic. Then as more tissue was destroyed, we got some new peptides. These peptides were self-peptides, but because the response was so inflammatory at the time they were presenting, our peripheral tolerance mechanisms didn't kick in. So now we've got this antigen that's a self-antigen that we're responding to, and this antigen that's a self-antigen that we're responding to. So these are the spread epitopes. Okay, this is a long one. So what are the things I actually want you to know about MS? So first off, it's immune mediated. I know that some people disagree as to whether or not it's an autoimmune disease, but we all agree that the immune response is mucking things up in the brain, and that's leading to demyelination, which is leading to disease. When you classify it as an autoimmune disease, because we're largely talking about CD4 positive T cells and a little bit of CD8 positive T cells, and we're not really talking about antibodies as much, it's definitely a type 4 hypersensitivity reaction. This is because there's presentation of CD4 positive T cells outside of the CNS, followed by this subsequent reactivation of T cells by antigens within the central nervous system. Just like all autoimmune diseases so far, there are a couple HLAs that are really associated with risk factor for MS. For MS, it's HLA-DR15 and HLA-A2. And also just being female, you've got a 3 times higher likelihood of developing it. We think that things kick off as a result of molecular mimicry, but then they are kind of spread over time via epitope spreading as new antigens become available for T cells to respond to. That's it.